Oh,
Yes,
okay.
sorry to record the pleasantries. So I'm going to start by introducing this guest speaker for today. That's Professor Hassan Zoaka, who was born September 24th at Kaduna. Professor Hassan attended the School of Basic Studies, ABU Zaria, before he gained admission into the honorable profession, veterinary medicine, where he bagged a Doctor of Veterinary Medicine. He obtained his MSc and PhD from the same institution. Upon his graduation, he served at Calabar before joining Borno State as the veterinary officer. He has a lot of experiences and he has attended over 50 local and international conferences and workshops. He has a credit of over 50 seminar and over 100 publications. So why is he the best person for this presentation? He is the head of faculty and now provost for the Postgraduate College of Veterinary Surgeons, Nigeria, amongst other qualifications he has. And I'm sure after this presentation, we get to know him better as he's going to be sharing us a lot of things. But before I call him to start speaking or share his presentation, I would like Dr. Tunji Nasir to give us few words of guidance before we start. Thank you, sir. And over to you.
Yeah. Thank you so much, our MC for the day, for the avoidance of doubts, to know the voice. This is Dr. Olatunji Nasir. And I'm really very happy today that my provost of College of Veterinary Surgeons in Nigeria and a very good mentor in the surgical field, Professor Hassan Zoaka, is our presenter for the day. When I looked at the topic, I found it very, very romantic. One way or the other, broken bones, like broken hearts, need mending. A case for intervention in fractures and all that. It's so, so romantic. And I'm sure that the prof will do a lot of justice to that topic today. We don't have any doubt that that's going to happen. And because of the fact that his side of trade in the veterinary world is a very rare one. We all need it, but at the same time, we don't all get it. And we don't even all have the how do I put it now? The expertise to actually trade in it. So he sits atop a very big position, so to say, because I dare tell you, most veterinary surgeons today are afraid of orthopedics, not because it is something that they cannot do, but the fact that it requires some real talent, for somebody to be an orthopedic surgeon. And that is why you don't find them like 12 a piece in any place. So anybody who is an accomplished orthopedic surgeon is someone that is revered, somebody who has got the patience, who has got the expertise, who is able to put two and two together and restore alignment, stabilization of the patient, and then a lot of animal concerns in terms of pain control and so many other things. So today, I think it's going to be a blast for us. And I'm sure that Prof will do a lot of justice to that topic. I'm curious to know how he's going to do that topic within 45 minutes. I wish we could have the next 2, 3, 4 hours, which may not even be enough for him to do justice to it. But I'm sure that today we are going to have it for just 40, 45 minutes, and we will all enjoy ourselves. So I have no doubt in my mind that as romantic as the topic sounds, we are all going to go out happier, falling in love with orthopedic surgery today. Thank you.
I don't know, am I to come on board?
Yes, sir.
Right away?
Yes,
Okay.
sir. Thank you, sir.
Well, fine. Thank you very much. I think I have been introduced already, so I need not repeat it, but that's what the first slide there is doing. I think I would take exception from the coordinator who said I'm the best. Certainly, I'm not the best. Yes, I'm one of those who dabbled into it and try to do one or two things, but there are other individuals out there that are better than we are. Another, I need to apologize that I'm just coming out of the cold. And so occasionally my voice might disappoint me a little bit. Bear with me if that happens. Another point of apology, I'm out of station. Consequently, I'm using my phone. And you know that when you're using the phone, once a call comes through, it cuts you off. And so bear with me if such things happen occasionally. Well, with that, I think I'm quite pleased to be given this opportunity to interact with my colleagues in the field of orthopedics. I give credit to Dr. Bala, who fashioned out this topic, broken bones like broken hearts and things like that. I don't think I have the capacity to come up with such romantic things, courtesy of Dr. Nassel, but I think Dr. Bala assisted in that particular direction. And to also offset the likelihood of too many interferences, unlike what I'm used to doing, controlling my own slides, I think this time around it's being controlled from the coordinator side. And because as I said, I'm not using my laptop, I'm just using this. So you keep hearing me say next slide, interrupting, the presentation here and there, but please bear with me as far as that's concerned. Can we have the next slide, please? So what I've tried to do is to structure my presentation. And in structuring my presentation, I came up with first a table of content. And in the table of content, what I try to do is to just mention, how I intend to make the presentation. And I will see what I can make out of the 40 minutes I'm given, because I have noticed that in spite of the effort I made, I still ended up with over 70 slides. So I would maybe be a little bit of a rush or skipping some of the slides that I think are too unnecessary, because I believe that these slides are going to also be made available to us to study even after the presentation itself. We'll start with a short introduction, trying to define what fractures are. We probably have done this over and over sometime in our lives, but it's a little bit of a revision, if I may use that word. Next, we'll try to look at fracture classification, because being able to classify a fracture is a very important thing towards the management of that fracture. Okay, so classification is a bit of a theoretical thing, but it's something that's necessary if we are to manage such a fracture ultimately. And then we're going to look at fracture healing, because in whatever intervention we try to do, healing is a very important thing, and we need to understand the dynamics of fracture healing, because that's probably one of the differences between carpentry and orthopedics. In carpentry, the carpenter fixes the wood and that's the end of it. Here we're dealing with a biological system. So the healing process has to take on. The fact that you've nailed it in place doesn't mean that the work is over. For a carpenter, it's over. For an orthopedic surgeon, part of the work is over, but we still have a large part to go. Then we're going to look at evaluation of fractures or the diagnosis of fractures. What do we do? How do we go about it? And then we'll get down to the real business of the day, which is the management. And under management, we'll try to say one or two things about the instrumentation. We'll look at the various options topically. We're not going in depth. It's not a presentation essentially on skill, techniques, and some of these things. So we're going to look at some of the options that are available to us in fracture management. And we'll also look at what rehabilitation programs can be undertaken to enhance the rate of healing and the quality of healing. And then we'll lastly look at referral services. Because a lot of orthopedic cases are referral cases, not all facilities have the equipment, have the expertise to deal with them. So inevitably, referral is usually the norm. Next, we move over to the next, and I think I just try to give a working definition of what a fracture is under the introduction, by saying it's just a discontinuity in a skeletal structure or in any mesothelial structure. But for the purpose of this discussion, we'll be limiting it to orthopedic skeletal structures. Because I believe most of us may have had things like penile fracture. The penis is not a bone, but we could have a penile. So mesothelial structures can get fractured. But for our own purpose here, we'll be referring, whenever we use the word fracture, we are referring to bones or skeletal structures. An easier definition is to say it is just the cortical discontinuity in a bone. That's an easier definition of what a fracture is. Now, bones or the skeletal structures, they have several functions in the body. I've tried to list out these functions. The protection of internal organs. We all know that the cranium is responsible for protecting our brain. The ribs are responsible for protecting the heart, the lungs, etc. So these are very, very important functions that the skeletal or the bones or skeletal structures perform. Next, they are a source of calcium and phosphorus. Hemopoiesis, we know that the bone marrow is responsible for blood production and that they are hosted within the medullary cavity of the long bones. It's the framework for the body. Without our skeleton, we'll probably just be a heap of muscle on the floor. Okay, so the skeletal structures are responsible for giving us a shape, a form. Okay, and then lastly, they facilitate movement because tendons and ligaments attach to these muscles, and by contractions of muscles, movement is possible and it takes place. Next, I try to, just in a form of revision, I just had a little sketch over there that should remind us of the anatomy, maybe DVM1, that's back to DVM1 actually. That should remind us of the anatomy of the dog. We're using the dog as a model. It doesn't mean that the dog is the only species of animal that encounters or in which fractures do occur. No, but we've chosen a model, and the dog is the model we'll be talking about, because most of the cases of fractures presented to our practices are actually in the canine species. We can see the different skeletal structures over there. So it's not an anatomy class, but you can see that right from the orbit down to the phalanges, the fore and the hind limb, we can see all the skeletal structures that are lying there. Now, we look at the classification of fractures, and I try to say that proper categorization of fractures, the type, location, and the severity allows us as clinicians to be able to plan very well on how best to manage that fracture. So it is important that we're able to classify a fracture, characterize that fracture, because it is instrumental in planning and in making a prognosis. Well, classification of fractures, they are classified based on several variables. One of them is based on the mechanism of injury. We can classify fractures based on that. It could be based on the anatomic location of the fracture or the skeletal structure involved. It could be based on the degree of displacement, the fracture pattern, the severity of the fracture, the degree of displacement, I've mentioned that, stability, as well as involvement of surrounding soft tissues. These are all criteria in which fractures, so we'll just briefly look at these ones. Based on the mechanism of injury, we can say fractures are essentially of three types. Traumatic fractures, these are the most common things that come to our clinic, which we attend to. And then we have what we refer to as pathologic fractures. Pathologic fractures are fractures occurring due to an etiology that otherwise is not sufficient to have caused a fracture, such as if you already have a nutritional imbalance or you are having a neoplastic condition affecting a bone. An animal simply jumping from a table to the floor might be enough to cause a fracture. These are pathologic fractures because there's an underlying pathology that has weakened the skeletal structure. And then we have what we refer to as idiopathic fractures. These are fractures that we inadvertently cause. Probably in trying to correct some other abnormality or things like that, we end up, causing fractures. I've seen cases in which, especially when you have students restraining animals during wet labs, and because quite often the fright is already there, they over-restrain it to the point that I've seen one or two cases in which they even fractured these animals in the course of restraint. Okay, so when we talk of idiopathic fractures, we're referring to those fractures that we are responsible for. Based on the anatomic location, we have classified fractures into two. One, it could simply be based on the bone that is involved. So we can have things like tibial fracture, femoral fracture, humeral fracture, phalangeal fracture. These are anatomic words. They don't describe the nature of the fracture. Likewise, it could be based on the location on that bone. So we can have diaphyseal fractures, epiphyseal fractures, metaphyseal fractures, condylar fractures. These are simply anatomic terms. So these have also been used in classifying fractures. We can classify fractures also based on the degree of displacement. And here we can have non-displaced fractures. We have three, sketches over there that you can see. The one on the left is a non-displaced fracture. There's a complete fracture of the cortex over there of the bone, but you can see that it's still in alignment. So this is a non-displaced fracture. The one in the middle is a moderately displaced fracture. You still have at least 50% contact between the fractured ends. And then we can have a severely displaced fracture in which there is no contact whatsoever between the two fractured ends. So these are illustrations to show us what we mean by a non-displaced, a moderately displaced, and a severely displaced fracture. Next, we can also classify fractures based on the pattern of the fracture. Okay, we can see several sketches over there that we have to tell us the different types of fracture. The one starting with the one on the left, we can have a simple transverse fracture, and that is one that occurs at right angle to the long axis of the bone, as you can see over there. The next to that, we have a spiral fracture, an oblique fracture. An oblique is one that is at an angle, as you can see. Then we can have a spiral fracture that goes round, the symmetry of the bone. Then we can have what we refer to as a comminuted fracture. Comminuted fractures are usually ones in which we have several fractures at the same place or crushing of the bone really. Then we have the sketches on the right. The first is a normal skeletal structure. Then we can have a fissure fracture. A fissure fracture, as you can see, is an incomplete fracture in which you have the fracture line running horizontal, not transverse to the long axis of the bone. We can also have an incomplete fracture. There's an example of it there. Forget about the simple fracture, we've seen one. And then we can have multiple fractures. When we talk of multiple fractures, it means we'll have several fractures, could be on the same skeletal structure, or you can have several fractures in different locations, or different skeletal structures, or the same skeletal structure. Then lastly, over there, we can have what we refer to as a compound fracture, although we'll be looking at it as either open or compound, closed fractures later. So we'll leave that out. So these are fracture classifications that are based on the nature of the fracture line. So this is also another criteria we use in classifying fractures. And this, of course, is more useful to us in practice because it tells us how bad the fracture is likely to be, and we can plan better, using that. Then these are fractures affecting the epiphyseal plates, and they are usually found in young growing animals. These sort of fractures are generally referred to as the Salter-Harris type fractures. And we can have them as Salter-Harris type 1, 2, 3, 4, and 5, depending on the severity and whether it's the metaphysis or the epiphyseal plate that is affected. In the type 1 Salter-Harris type fracture, you have a derangement between the epiphysis and the metaphysis, but none of these is fractured. In the Salter-Harris type 2, the metaphyseal end has a fracture on it, as we can see. In the type 3, the epiphyseal end has a fracture. In type 4, you have a fracture cutting across both the epiphyseal and the metaphyseal parts of the skeletal structure. In type 5, you have the metaphysis and the epiphysis crushing into each other, okay, obliterating the growth plate that is supposed to be in between the two. So that's type 5. So when we have fractures affecting the epiphyseal plates, this is usually the criteria, or this is the classification modality that we employ in it. Now, based on the severity, we can say we have simple fractures. And when we talk of a simple fracture, we're talking of one in which we have a simple fracture line in a skeletal structure. Multiple fractures are when there are several of them. Comminuted fractures can be said to occur when we have practically, we say, crushing of the bone or multiple fractures on the same skeletal structure. Then based on the stability of the fracture, we can have stable or unstable fractures. Of course, as the word goes, unstable ones are more problematic than stable ones. Stable ones are complete fractures in which anatomic symmetry is still there. In an unstable one, everything is moving and it's unstable, and if you don't do anything about it, additional damage can be caused to soft tissues. Based on the involvement of soft tissues, we can also classify fractures into types 1, 2, and 3. In types 1, it's usually when there is a communication between the interior, between the skeletal structure and the exterior, that is due to the bony structure that is fractured piercing through the skin. In type 2, it is the external cause of the fracture piercing the skin and contacting the bony tissue. In type 3, there is variable level of soft tissue damage. And we even have the type 4. In type 4, there's practically an amputation. This is a situation where probably the limb is being held only by the skin or a few shreds of muscle tissue. Okay, so we could have the type 1, 2, 3, and 4, depending on the severity. Now let's start looking at open fracture management. I think this is simply based on, okay, these are notes. I decided to just put them there putting a little bit of flesh onto the different types of fracture. I think we will have time to read this at the end of it. I just said, looking at it the way I had it presented earlier on, if somebody looks at the slide, it may not make much sense to him. So I just decided to put a few notes on it. Now, based on the communication with the exterior, we could have closed and open fractures. Older books refer to open fractures as compound fractures as well, but they are more appropriately now referred to as open fractures rather than compound fracture. So when we use the word closed fracture, we are referring to a fracture in which there has been no communication between the fractured bones and the exterior. When we talk about open fracture, on the other hand, there is a communication between the skeletal structure and the exterior. It could be type 1 or 2. It could be that it's the bone that pierces the skin, or it's external. The piercing might be from the external part. Now we move over to the next aspect. We've talked about fracture classification. Now let's look at fracture healing. And healing in orthopedics simply refers to restoration of the fractured skeletal structure to its normal anatomic and physiology. Anatomic means the structure. Physiology means the function. So for a fractured skeletal structure to be so attended to so that the structure is maintained, or the structure reverts back to what it was in the pre-fracture state, and that the limb can now be functional, or the structure cannot be functional. That is what we refer to as fracture healing. And there are three key things. So once reduction has been achieved, blood supply is intact, what the fracture just needs is immobilization. So when we talk of immobilization, we are referring to stabilizing it such that there's no movement at the fracture end. When we talk about the use of the different fracture protocols, we'll be talking of those that confer real stability and those that only confer partial stability. Then there are factors affecting fracture healing. We'll try to define what healing is. We can look at factors affecting fracture healing from the perspective of, or we'll give them these three broad classifications: patient-related factors, based on fracture characteristics, and then the treatment considerations. When we talk of patient-related factors, we're talking of things like age. We all know that fracture heals faster in younger animals. The overall health, diseased animals will take a longer time usually from fracture to heal, underlying other medical conditions, etc. Under fracture characteristics, the type and the location, the severity of the fracture is a very, very important factor. The severer a fracture, usually the longer it takes for healing to take place. And then, of course, under treatment consideration, immobilization. The more stable the immobilization, the faster the fracture will heal, and the less likely we are to have problems. It could also be classified as either based on as biological factors, mechanical factors, nutritional, or lifestyle factors. I just also attach a little bit of note onto it because we can also read the slides after the presentation. But these factors are there and their effects are there. Now, stages of fracture healing. Different books or different authors have classified these stages variously or differently. But this is just a working, so don't assume that this is the only way you can classify fracture healing. There are other ways that have been classified by other authors. But we are looking at it as basically from three key areas based on the activity that takes place. First, we have the inflammatory phase. Once a fracture takes place, bleeding will take place or hemorrhage will take place, a clot is formed, cells migrate to that part, inflammation takes place. That is what I'm referring to as the inflammatory phase. And that is usually the very first phase. After that, healing now commences to form what I refer to as the reparative phase, which results ultimately in the formation of what we call the soft callus. And after the hard, soft callus, we now have the hard callus, forming at the end of the day. So hello, are you still with me?
Yes,
hello?
Sir. Yes, sir. We are with you.
Sorry,
I just can hear you.
We can hear you.
Thank you. A call came through, so it almost disrupted my business. Sorry about that. Then lastly, we have the remodeling phase. So after the hard callus has formed, usually the bone looks rather abnormal because you end up with a bulb kind of at the point of fracture healing. So the body now attempts to restructure the bone back to its former anatomic location, form. And that's where the remodeling takes place. It pushes out or it chips off all those additional, layers that we have so that the bone looks as close to normal as possible. But remodeling is never 100%. I think we need to know that. I have a little sketch over there that gives us a guide. as to how long it takes a fracture to heal, depending on the nature of the fracture as well as the kind of fixation. Okay, this is part of the healing process. In the first line over there or column, what we have is when you do an external coaptation or an IMP, these ones do not offer complete immobilization. So what you end up with is this guide. So you can see that the younger the animal is, the faster the healing process. The column on the right, on the other hand, talks about when we use a plate fixation and plates. Sorry, the next slide, please. Plates will usually give us a very solid fixation. And that is why you can see that the healing time is shorter in the right column than compared to the left. Okay, but we'll be looking at these different, management protocols later. Now, how do we say, or when do we say a fracture has healed? It is important that you are able to define exactly when a fracture has healed. Otherwise, you may end up removing your implants, or you may end up taking off the coaptation prematurely, and then you might be back to square one. It is important that we're able to assess a fracture and know that healing has actually taken place. Now, in assessing a fracture, there are two things that we usually look at. One is the clinical assessment, and the clinical assessment simply refers to what you see, what you feel on the clinic floor there without having to resort to radiography. And there are certain things we look at for. First is the absence of pain. We know that fractures are associated with extreme pain, one of the highest levels of pain, really. So when you can palpate that area and the animal does not seem to respond to any form of pain whatsoever, it is suggestive that that fracture has healed. Secondly, the ability of the animal to use that part of the body. When there's a fracture, the animal naturally will refrain from using that particular limb or part of the body. So when the animal can now comfortably use that part of the body, it is suggestive that healing has actually taken place. The third is rigidity at that site. So if you hold on to that particular part that was fractured, where you could pick up a crepitus initially, now it's very rigid. You can't pick up a crepitus. You can't even move it around. Then it is highly suggestive. It is, however, irrespective of whatever these findings are, it is highly suggestive that you go for radiography before you remove an implant or take off your coaptation device. So radiographically, there are also three things that we look out for to indicate to us that a fracture has actually healed. First is cortical and medullary continuity. We've said there's cortical discontinuity in the fracture. So that discontinuity should not be visible anymore. The bone should look, the cortex should look smooth and continuous. The medullary cavity should also be smooth and continuous. That is an indication that healing has taken place. There should be mineralization of the callus. So the point of fracture healing should not appear porous or of a different density from the normal bone itself. Okay, it should appear normal. And the absence of gaps between the fractured segments. So these are criteria. So once you've been able to establish the clinical indices over there that I earlier mentioned, that fracture has taken place, and you've confirmed it by a radiograph, and you saw all these, it is clear to us that a fracture has now healed. You can take off the immobilizers, or you can take off, the implants, if implants have been used in that case. This is a radiographic guide to fracture healing. As I said, I put in some little explanation so we can look at it. At 7 to 14 days, this is what we see. At 14 to 21 days, 2 to 6 weeks, 4 to 8 weeks, and 8 to 12 weeks. There might be slight variations with different authors, but this is a general guide that these are the factors. So when you take a radiograph or when you are radiographically assessing a fracture, these are the variables you are likely to see. Now, when we talk of healing, it's not in every situation that healing progresses normally. No problem, everybody is happy, etc. No, there are situations in which complications occur, and healing might not go the way we have it planned. First, one of the complications we encounter is delayed union. We have given you a chart over there that says a fracture is expected to heal after so-so or at so-so time. There are situations in which it might take twice that time, 3 times that time for a fracture to heal. Okay, so when you have a fracture healing slower than intended, we refer to that as a delayed union. Age could be a variable. Some level of infection could be a variable. The use of implants, the wrong choice of implants, things like that, improper fixation, etc. This could all delay the rate of fracture healing. Malunion is also another factor that will affect the rate of, that could be viewed as a complication of fracture healing. In this case, healing has taken place, but the bones are not aligned in their normal anatomic form. They are bent, they are crooked. That is what we refer to as a malunion. Non-union is when a fracture simply refuses to heal. So when you're having a fracture in very old animals, or when there's an interjection of a foreign material between the two cortices, you are likely to end up with a non-union, okay? Or when there's a neoplastic condition affecting that skeletal structure, you may end up with a non-union fracture. And then infection, of course, we all know. This is the worst threat to an orthopedic surgeon, to see pus, to see signs of infection. Because what that means is that you're back to square one, or you're probably even below square one, really. Because first, you have to go back, remove all your implants quite often, deal with the infection. After you've dealt with the infection, you repeat the surgery all over again. So an infection is the last thing that a surgeon wants to see, whether it's orthopedics or any other procedure. These are strategies for optimizing fracture healing. Ordinarily, healing will take place once the fracture is immobilized, but there are certain practices or activities that, when undertaken, will enhance the healing process. First is nutrition. We know that nutrition is important for wound healing, irrespective of it, especially ensuring that there's adequate calcium and phosphorus will assist us in the healing process. Physical therapy, gentle exercise, stretching, activities are also very useful. Pharmaceutical interventions, the use of things like growth factors, bone stimulators have been proven to speed up the rate of fracture healing. Then rest and immobilization, we all know what that means. You can't have an animal, you've just attended to a fracture, and then you allow the animal to start running all over the place. It's going to be counterproductive to the healing process. So these are little practices that we can do to optimize the healing process. Now, we've moved over to the third component of our presentation, which is fracture evaluation and diagnosis. How do we evaluate a fracture? How do we make a diagnosis of an orthopedic disorder? So I gave a working definition here. I said this refers to a series of defined and coordinated activities undertaken to elucidate the location and severity of injury or deformity, if we're talking of a skeletal structure. So these are what we refer to as fracture evaluation or fracture diagnosis. And this encompasses most of the things we do under normal clinical examination. If we start with what we call the general examination, and then history is taken usually, and then we have the clinical examination being conducted, and then laboratory evaluations are also undertaken. Now, after this, we now zero down on what we refer to as the clinical examination. And under the clinical examination, we all know that it's a standard thing that we take the temperature, the pulse, and the respiratory rate. This constitutes what we refer to as the vital parameters. After getting the vital parameters, it is important that we conduct what we refer to as a visual evaluation. This is very important for us. And when we talk of visual, we're referring to those things we can see with our eyes without necessarily having to even touch the patient. These are what we refer to as visual evaluation. So under the visual evaluation, we will be looking at gait. How is the animal moving around? We'll look at the stance of the patient. Is it able to uniformly place weight on all the limbs? Or does it seem to have a preference or inability to use a particular limb or a particular part of the body? It's important that we're able to establish that. After looking at the visual evaluation, we now go down to what we call the physical examination itself. And the physical examination, of course, involves having to come into contact with our patient. So under physical examination, we know that the three key variables that have been useful for us are the auscultation, palpation been eliminated, the stethoscope killed percussion, just as the butterfly is also out to kill the stethoscope. So if I kill you, somebody kills me. Percussion used to be the air thing, but with the use of the stethoscope, you can get the same thing, better, sound response. So you don't need, to a large extent, we hardly do the percussion. But as I said, the auscultation took over. That's the use of stethoscope and things like that. Now percussion has taken over. Now let's zero down on palpation, because we're talking of orthopedics, and that's the aspect that is most important to us. In palpation refers to the set of practices we use our physical hands to do. By massaging, by touching, by stretching. So in palpation, we are trying to assess the girth of the muscle, the activity, the resistance to your trying to extend and flex the various joints. If there's pain, there will be resistance. You look at the range of motion. How well are you able to establish normal range, or is there resistance to that? You do a gait analysis, as I've said earlier mentioned. And then, of course, pain perception is something that you look out for as you move along. As far as whenever we're talking of orthopedics, I don't know how many of us have had the misfortune in life of having sustained fractures or having to undergo orthopedic procedures. I've always imagined, at least read it in books, that these are very painful procedures. But I have to tell you that having gone through 4 surgeries within the past 3 years, I've come to appreciate exactly what pain means, especially as it affects orthopedic procedures. And it has, to some of us, it has affected some of us so badly that we're finding it actually. Again, I was telling somebody that I might find it difficult to get back to surgery, having tested surgery myself and having realized the kind of pain that patients go through. I don't think it's reality, it has to be done, but it's one of the most painful experiences. So pain definitely is one of those things we have to deal with. Next, I try to put in a little bit of information to what we mean by patient history, visual inspection, the palpation, and things like that, so that when we read the slides, after the presentation, it will make some sense to us. Okay, so the next slide. We also try to look at palpation techniques on the next slide, and we look at it from the perspective of the systemic approach. Now, palpation is very, very important, and that's why I took the pains to put some notes down there as it relates to palpation. Because in assessing an orthopedic structure, your hands are very, very important. Your ability to discern noises from within, the types of noises, is it a cracking sound, is it a crepitus, and things like that is very important. Your ability to feel if there's a swelling, if the tissues are normal, if they are tensed, these are all very, very important factors. It's not in every situation that it must be a fracture. There might be other musculoskeletal conditions that you'll be able to pick up by palpation. So, and that's why I've highlighted that quite significantly. So we have the systemic approach to palpation. We have the gentle touch, comparative assessment. Comparative assessment means whenever you conduct an examination, a palpation, it is always recommended that you go back to the normal part of the body and repeat the same thing so that you do not overinterpret. Because if you interpret only one part, or sorry, you palpate a single part and you don't palpate the contralateral part, the tendency is there that you might misdiagnose or misjudge certain activities. But you do it on the normal limb, and then you are able to tell what really is a disorder. Then identify, of course, all the abnormalities, and you take note of these abnormalities. On the next slide, I also try to put a little bit of notes on what we mean by gait analysis, because gait analysis is very, very important for us in making a diagnosis of fractures. It is an extremely important component, and it involves we having to move the animal around, take it on a walk, trot it, and then see how it moves around, as I mentioned earlier. So I put in a little bit of notes on it so we can read that up later. Now, the next slide talks about joint range of motion and assessment. I've also tried to, put in a few notes in there so that we can also study it as well. I've tried, along the line to strike a balance between having slides that people can study later and still make sense out of it, and at the same time, trying not to be too wordy about the whole thing and not making it too much of an academic exercise. Okay, so I try to, come up with something that we can still find useful even after the presentation. So if you think it's a little bit too wordy, please just forgive me. This is the basis upon which I had to put in a little bit of note in it. So in assessing joint range of motion, I try to look at it from 3 different perspectives. The passive joint evaluation, the muscle palpation, and the geonometric measurements. I believe that most of us may not have seen the geonometer. It's a piece of instrument that actually we can use in assessing the angles, and because we know of what the physiologic angles of the different joints of the body are, when there's a deviation from that angle, we'll know that there's a problem, okay? But usually we just visually assess this range of motion and we come up with our own judgment. Now, next, in assessing a fracture, it will never be complete without looking at diagnostic imaging. Okay? It will never be complete without diagnostic imaging, irrespective of what your clinical findings are. It's usually advocated that you go to diagnostic imaging so that you can make a confirmatory diagnosis. Without a radiograph, whatever it is you have is just tentative. You require a radiograph to be able to confirm that. Of course, when we talk of diagnostic imaging, it's not just about radiography. There are other imaging modalities, such as computerized tomography, MRI, that are also used in evaluating skeletal structures, especially if you are dealing with the brain or the cranium and the vertebral column. MRI comes in, computerized tomography comes in. But in most of the orthopedic issues we deal with that essentially affect the limbs, radiography usually suffices. And I just had two examples of radiographs over there, how relevant they are, and what they can show us that we might not be able to actually ascertain by simply, simple physical examination. Hello, am I still with you?
Yes, sir.
Yes,
Yes, sir.
yes, sir.
Yes, sir.
You are. All right. All right.
Yes, we are with you.
Okay, so I think the next slide just shows us some radiographs so that we can see how bad things can be. And the one on the left, as you can see, is an easier kind of fracture. You might be able to palpate and make some sense out of it, but you can see the one on the right, which is a lot more complex. Without a radiograph, it will be difficult for you to be able to ascertain and really have a grasp that this fracture is this severe. Of course, it's unstable. You'll be able to pick up that there's a fracture there, but how bad that fracture is, you require this radiograph to be able to do that. And without establishing this radiographic diagnosis, I've seen situations in which we had femoral fractures that were this bad, and people just went ahead and put on a POP on it. This fracture will never heal with a POP. But if they had taken a radiograph, they would have known that this is a case for referral. You don't have the equipment to handle it. You don't have the expertise. Don't put in a POP on a case like this. Femoral fractures generally are not amenable to external coarctation. Internal fixation is usually required, except, of course, when we have fractures associated with that. Now, cases, they are young animals usually, and because the bones have been severely weakened, we generally do not want to open them up. Because when you open them and put an implant, the implant will further fracture those skeletal structures because of the level of weakening. Okay, so in such cases, those are the only cases in which external immobilization is allowed when you are dealing with things like femoral fractures. I think with that, we just said one or two things about next, the examination for orthopedic emergencies, and that's what the next slide tries to capture. And I specifically brought this on because when we're talking of orthopedics, let's always have it in mind that any form of force that is strong enough to break a bone will also be sufficient to cause a lot of other damages and pathologies within the body. And quite often, mistakes have been made where we overlook the soft tissue injuries and we concentrate on what is more obvious, which is the fracture, only to realize later, albeit sometimes too late, that you actually had a more serious problem than the orthopedic problem itself. I learned this from experience. There was a referral there, we got carried away, we took an x-ray and we saw a fracture there. Okay, fine. We arranged that tomorrow morning we are coming to intervene. The animal was hospitalized. This animal was making active cavity. It was filled with blood. This animal actually had a splenic fracture. And it has, when we took another look at the radiograph that we took at the obvious fracture, we'll have noticed that there was this ground glass appearance in the abdominal cavity, which is suggestive of fluid accumulation. And if we had known of fluid is in there, if it's blood, we'll have known that we have an emergency that is more serious than even the orthopedic. I am saying this because we need to know that even when we have a fracture, don't be carried away with that fracture. Look out for soft tissue injuries. They may be more fatal than the fracture that you're dealing with. And that's why we said, in addition to the orthopedic, it is important as well as the thoracic cavity for blood, for hemorrhage. Neurologic examination, because at the end of the day, however good do you think you've performed an orthopedic procedure, if at the end you realize that that part had been paralyzed or the nerve supply to that part has been transacted, that was not to be to give a prognosis with doctor and sound concepts. Make sure you conduct a neurologic examination, examine the abdominal cavity as well as the cavity. If radiograph of the limb, if there are parts of the abdominal cavity that have been captured, or the limbs of the thoracic cavity, depending on which fracture you're dealing with, if they've been captured on the radiograph, also endeavor to have a good look to make sure there's no fluid within these cavities. Okay? It tells you that you're probably having urine within the abdominal cavity, which means the bladder will have been ruptured. So your problem is not just the orthopedic injury. So whenever you have this, as I said earlier, any force strong enough to break a bone may cause other injuries. Look out for those other injuries because they may be more fatal than the orthopedic problem you think you're dealing with. Of course, lastly, we have the radiographic examination. It's always going to be there as far as we're talking about orthopedics. Now, on the next slide, we'll try to give what we refer to as signs of lameness, signs of a fracture, orthopedic disorder. Now, I try to look at these from two perspectives. There are what we refer to as general clinical signs, and there are those that we refer to as site-specific. When we talk of general, we mean these are things you see irrespective of where the fracture is. Usually, lameness does not tell you exactly which bone is affected. It simply tells you that this part of the body is likely to be affected. Pain is also likely to be there. Pain is not specific to any particular. Crepitations might be a little bit specific. Bone discontinuities or instabilities, skeletal instability, swelling, signs of predisposition. So these are general signs, irrespective of the bone that is involved. You are likely to see these particular signs. On the next slide, we'll try to mention some what we refer to as site-specific signs of lameness. And in the site-specific, you can see that in the limbs over there, we said there will be acute lameness. The limb that is affected is likely to be shortened, and there will be deviation, indicating that, yes, there's a fracture there. If the spine or the vertebral column is affected, nervous signs are likely to be there. Pain will be there. There might or may not be inability of the animal to rise. There might be signs of urinary or fecal incontinence. These are all suggestive that your problem is on the spine. If the problem has to do with the jaw, the mandibles, the maxilla or the mandible, apprehension and mastication disorders. By apprehension, we mean the ability of the animal to grab food. Mastication means chewing. These are likely to be compromised. There might be facial distortion and blood-tinged saliva. So when you see this, it is suggestive that your problem is localized to the jaw. In the case of the tail, there will be abnormalities of function and carriage. When ribs are affected, respiratory disorders might be obvious. When the pelvis is affected, urinary tract injury might be associated with it. Lameness and inability of the animal to stand might be things that we may see. On the next slide, we try to put some notes, okay, into some of these, what I call interpretation of orthopedic findings. So radiographic evaluation, physical examination, synthesis, identification of lesions, prognosis.
Doctor, I believe that there is a scarcity of food in Nigeria, despite the hoarding and storage.
Please, can somebody mute his microphone? I think somebody's microphone is on, and yeah, please mute your microphone. Yeah. Thank you very much. So I try to put in some little notes in there so that we can read that and study that aspect later. On the next slide, we'll try to look at treatment recommendations and prognosis. And just generally, we have what we refer to as targeted treatment, rehabilitation and recovery, and prognostic evaluation. So I try to put a little bit of note on these so that we can study it further at our own spare time. I'm sorry, I'm pushing a little bit fast because, as I said, there are over 70 slides, and I only have 40 minutes to accomplish this. So I'm trying to do the best that I can. Now let's get down to, I think we're coming down to the real thing now, fracture management. Please, 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 mute your microphone, please. Please, mute your microphone, please. In fracture management, I've decided.
Hello?
Hello?
I think the back end should mute everyone.
Okay.
So we only give permission to ourselves to talk later.
Thank you, Chairman. Fracture management, other fracture management, I've decided to break it up into
Prof has been muted.
You are muted, Prof, too.
So you can unmute yourself.
Yes, Prof, please
unmute
unmute yourself. Yes.
Okay. Am I back?
Yes.
Yes, sir, you are back. Thank you, sir.
Okay. So thank you very much. I said we are now on the real thing, which is fracture management. The others are preambles that will lead us to fracture management. We are now at the real thing, the terminal end of the presentation, fracture management. And I said for convenience, I've decided to break these into 4 different components. What I refer to first as general management, and then conservative management. The third category are closed reduction and external immobilization, and then open reduction and internal immobilization. And lastly, what I refer to as miscellaneous techniques. We'll look at 1 or 2 things. And so we're going to look at fracture management from these perspectives. Now, looking at general management, I think we're still, some microphones are still on. Hello. So under general management, these are the set of practices that are referred to as general management. And they are often practices or activities that we have to undertake to stabilize the patient. Surgery in itself is not something you just immediately rush into, except if you're dealing with an emergency. Otherwise, please look at this, stabilize the patient. Make sure the patient is in a position to survive the surgery. There is no point taking the patient into surgery only to end up with a dead patient. So the first thing is, these are the practices I refer to as under general management, and they are usually my first line of intervention. First, I stabilize the patient. When the patient is presented, if the patient has lost blood, I try to correct that blood loss, arrest hemorrhage, administer fluids. Depending on the extent of blood loss, it could be blood transfusion or it could be the administration of other fluid. If the animal is in shock, I make sure that I reverse that shock. If it's an imminent shock, I make sure I arrest it progressing into actual shock. If there's any identifiable life-threatening condition, I deal with it first. An example is what I mentioned earlier, a splenic fracture. When you have a fracture of the spleen, blood is oozing out. I will have left the fracture alone, attend to that first before reverting to the fracture, okay? So any life-threatening injury should be treated first as an emergency. You restrict the movement of the animal, then support the fracture with splints, okay? So even if you intend to do an open reduction, at that moment, apply a splint to stabilize the fracture, because fractures do not occur the way we usually present them in pictures, clean. Usually when you have a fracture, the edges of the bones are jagged, they are pointed. If you allow that to continue, just move, swerving all over the place, it's going to puncture. A closed fracture could become an open one. Likewise, blood vessels and nerves that are adjacent to the fracture site might also get damaged. So it is important that you immediately immobilize temporarily that fracture. So these are what I do as a first line of intervention. And I refer to this as general management. Okay, this just summarizes everything. We say general management. These are the steps. First, the general management I mentioned. Then, of course, the use of antibiotics and analgesics, if indicated. Because whether or not we like it, if you are going to do an open reduction and internal fixation, the possibility of an infection is heightened. So animals should be on antibiotics way ahead of that, planned surgery. Analgesics, absolutely necessary. In the olden days, I think when we were students, analgesics were news in veterinary surgery because we are not using analgesics. Because then the belief was that animals need to feel pain to discourage them from using that part of the body. So even when animals are presented whining, can't eat, fever, heightened temperature because of the pain and everything else, we'll still go ahead, we'll take them into surgery, we'll cut them up all over again, and then you have the healing process and no analgesics are given, and it was torture. But in those days, that was the thinking. But I think over time, everybody now appreciates the fact that you are to assume, or as clinicians, we, especially when dealing with small animals, the golden rule is to assume that anything that will cause pain to a human being will also cause pain to a patient. And that the extent of pain to the human is similar to the extent of pain in your patients. So that will guide you on knowing that it is important that analgesic must be given, okay? Pre-surgery and post-surgery. Of course, the consent is another thing that we tend to overlook sometimes. Hardly do you go to veterinary practices. Maybe a few people like Dr. Tunji, Abiade, and Bala Mohammed probably do it, but we often do not obtain the signed consent of clients before we go into surgery with their patients. It is important that we do that. That takes off any liability on your own part should an unplanned event occur in the course of surgery. If you go in for a human surgery, all the 4 surgeries I had to undergo, I had to sign my consent form myself. Of course, since I was with them and I wasn't unconscious, so I signed the consent form. But it's important that we get consent forms signed by our clients before we go into surgery. Anything can happen. Anesthetic complications something could just go out of the way. You may have made the best plan on earth, but you may end up losing that patient. These, insulates you, except, of course, if it can be proven that there was an obvious fault on your own part, in which case they can still sue you. But it's an aspect we tend to overlook. Please, we should not overlook it. If you have to go into surgery, make sure a consent form is signed by the client. Number 3, manage soft tissue injuries. I've talked about that. Deal with that. It's not always that we have fractures in which there are no soft tissue, injury accompanied with it. So when there is such a situation, please go ahead and attend to that wound. If you do not attend to that wound and you try to just deal with the fracture, you probably will end up with a complication. Of course, lastly, we have about stabilizing the patient. Hello, are you with me?
Yeah, we are with you.
Yes, sir.
Thank you.
Yes.
Yeah, still the same thing. Another phone call coming through. So I listed on the next slide, please. I've listed quite a number of things that we do in an attempt to stabilize the patient. On the next slide, it's listed over there. These are different types of fluids. How we go about, determining the maintenance or the replacement volume. This is just one way to compute. There are so many ways of computing the amount of fluid to be administered. This is just one of the ways. So whichever way or whichever formula in fluid replacement you employ, whatever formula seems to work for you, please stick to it. But you realize that different books or different authors will give you different recommendations, okay? My recommendation down at the bottom here on the maintenance volume takes into consideration whether it's a young animal, an old animal, apyrexic or pyrexic. In pyrexic cases, fluid loss tends to be faster, so the rate of the replacement has to be faster. In a young animal, fluid content is generally higher and things like that. But as I said, there are other options again on different ways of also computing even the replacement volume. But these are suggestions on what you can do to stabilize the patient. Then when it comes to blood transfusion, also this is also another recommendation. There are also other formulas and other ways of coming across the amount of blood to be infused in the patient that requires blood. But this is one such way, so you can study it up later. We've talked about, the treatment of shock. It is important to do that. And I've mentioned it earlier. I've just, attached some notes to it, so you can also study that later on. Treat any life-threatening injury. And there are 3 categories of injuries that are important. 1, internal injuries in the abdominal or the thoracic cavity, and 2, cranial injuries into the brain. These are vital and these are potentially fatal. You must attend to them before you look at your fracture, before you attend to your fracture. You don't leave these injuries and go ahead trying to manage a fracture. No, a fracture can wait. These injuries may not be able to wait for you. Next slide. We're getting a little bit closer now. We're looking at specifics, reduction and immobilization. What do we mean by fracture reduction? When we talk of fracture reduction, we are referring to a set of practices that we employ to ensure that the normal anatomic outline of that bone is restored. When you have a fracture, the bones might be, you may have displacements, overriding may occur, angulation may occur. So, but reduction simply means bringing it back to that position. And of course, if you are dealing with femoral fractures, we all are familiar probably with what we refer to as angulation and tugging, because that's the only way you can reduce a femoral fracture. It's never possible for you to hold one segment, the other, and you think you can pull them apart. The mass of muscle around the thigh ensure that whenever you have a complete femoral fracture, overriding tends to become a problem. So to get them back in position, we do what we refer to as angulation and tugging. We put it at an angle, put pressure on it, we force it down so that we can realign the fracture. Immobilization, of course, refers to the use of any other thing to make sure that we maintain it in that fixed position for healing to take place. And then, of course, we talk about mechanical support. So there are some notes over there that we can study later. Now, principles of fracture stabilization. 4 things are important in stabilizing a fracture. 1, that anatomic reduction has been achieved. Bones have been realigned. That's what we mean by that. Rigid fixation, meaning you've been able to use something internally or externally to ensure that that bone that was initially fractured is now in position and will remain in position until healing has taken place. Preservation of blood supply. It's what, irrespective of how incredibly beautiful your surgery may look, if at the end of the day, there's no blood supply to that part of the body, work done is 0. You are going to lose everything. You end up with an amputation of that particular limb. So preservation of blood supply is very important. So in the conduct of surgery, it is important you ensure that your blood vessels are not unnecessarily cut or damaged. These blood vessels supply parts of the body. And if you damage a major vessel supplying a part of the body, you end up with a bigger problem than what you started off with. So it is important you ensure that you preserve blood supply to the various parts as much as possible. Early mobilization. After fracture management, the earlier you can get the patient to start placing weight on that part of the body, the better for you. Okay? Because pressure, and that's the principle behind what compression plating. When we do a compression plating, healing tends to be faster than when you do a normal plating. And the principle is just this, that when you place load on a healing bone, it tends to heal stronger and faster. Okay, so early mobilization, it doesn't make it's not a good policy to completely immobilize an animal that has been fractured, putting it in a cage that is too tiny for the animal to even be able to stand. It's not called for. Allow the animal to be able to stand whenever it can. You probably don't force it, but allow it to be able to do that whenever it can. And whenever the animal can, it would attempt to stand on its own. So early mobilization is very important in fracture healing. Next, we'll just try to present some of these things. I think we're familiar with quite a number of these. Some we may not have been too familiar with. You can see over there, we have what we call boots or canine boots. So these boots are usually used when we're dealing with phalangeal or or metatarsal, metacarpal injuries. There are these boots. So when we place them, they create some kind of immobilization. Sometimes when we treat soft tissue injuries, preparatory to the management of the fracture itself, we could place on some of these boots to assist. They help also take weight off from the distal aspect of the limb. Then we have a system of stretchers over there. Of course, when you have a patient that is fractured, we do not advocate that you keep pulling that animal, carrying it anyhow. There should be a stretcher in which it can be strapped and gently moved without causing more harm than what was there before. Okay? We also have a neck brace. Probably we've been seeing neck braces used in humans. We may not have seen them, but there are neck braces that are meant for use in our veterinary patients as well. On the next page, we have different types of splints, as you can see. These are all things we use for emergency fracture management, okay? Or they could be, depending on the kind of fracture you're dealing with. So if you're dealing with a stable fracture, especially of the distal extremities, it might be because of the thin muscle supply over there, displacements, overriding are not often associated with such fractures. So it's possible that any of these planes can be used, okay? In addition to this, of course, this is the traditional thing, the modified Robert Jones bandaging. And then we all know the almighty POP that we used to, but of course, we thank God that the fiberglass cast has almost eliminated the use of POP now. But I've seen one or two cases where people still use POP. For God's sake, migrate. If you are still using a POP, migrate to the use of fiberglass cast. It's far superior to POP. You need fewer layers of it. It's not as bulky as POP. Water doesn't mess it up the way water would mess up with the POP. Okay, so migrate to the use of the fiberglass cast. It's stronger, it's firmer, withstands water, and it's not as inconvenient to the patient as the POP is. Well, these are just what we refer to as working cast or barbed, cast. We apply them also, especially when we're having soft tissue injury underneath. We could put on a cast, but split the cast so that we can occasionally open up the cast, deal with the soft tissue injury, dress the wound, and put back the cast and just tape it in place. So by having the cast in place, the stability is still conferred. So you have wounds over there that must be attended to. So if you close up that wound and you don't attend to that wound, with the humidity and the warmth under the cast, you might end up with a maceration of that tissue. And at the end of the day, you will lose that. Okay, so any of these practices can be done. Of course, you can see an example here of a fiberglass casting that has been applied on this patient to stabilize fracture. I think these were multiple fractures affecting the scapula and the radial ulnar. So it had to be taken around the entire body of the patient.
Prof?
Hello, sir?
I think we have overshot the time.
Okay, let me
now, yes.
So let me round up within the next 1-2 minutes. Okay, sorry.
Okay. Yes.
Surgical interventions, open reduction and internal fixation, percutaneous pinning. These are external fixation. These are things to be done. These are definitive open fracture management protocols. IM pinning, bone plating, Kirschner wiring, cross pinning, tension band wiring, bone wiring, bone stapling, smiling nail application, external fixation clamps, use of bone screws, and plating. These are all open reduction and internal fixation modalities. These are just some sketches to show you the application of those things I've mentioned. Sorry, my time is over. I wouldn't be able to go through the specifics of the application, but these are external fixation. Sorry, next slide, please. Next slide. Okay, these are the various techniques that I've mentioned. Next slide, move on. Okay, you can see the use of the bone wires, the bone plate, mandibular fractures, limb fractures, etc. Next. Next slide, please. You can see the use of the IM pin. You can see the external fixation clamps over there. Next slide. Bone plating, use of external clamps, use of rush pins on the left side. You can see next. You can see the use of clamps and bone cement without having to use the external clamps. You can see the use of rush pins and double IM pinning. You can see various scapular fractures, how they are being handled by either use of screws or wires or figure 8 tension band wiring. Next slide. You can also see the use of the different techniques. Let's just move on. Move to the next slide, please. Well, these are pictures showing mandibular fractures over there being handled. You can see the external clamps, etc., etc. Move to the next slide. Post-operative rehabilitation is equally important. You can see different. Well, most times we don't have the luxury of in veterinary practice of having what the picture we have at the top over there with our patients lying on bed cool with the lips hanging up as we do in human patients. But it's a possibility. Underneath over there, you can see a working, cramp over there where the animal's rear quarters are supported and he doesn't have to step on it. Next, move to the next. These are forms of rehabilitation. Next slide. These are instruments that we can use. Next slide. These are orthopedic instruments. Next. Hello?
Yeah, we can hear you.
So we're on referral services.
Referral service, okay. I think I lost my... Okay, thank you. Referral services, well, we said what's the significance? We mentioned the significance, providing access to specialized expertise, patients are better treated and things like that. But I've listed, significant reasons why or importance of referral services. It is important that when you see a case that you do not have the facility or the expertise, please do not, for economic reasons, insist on handling that case. Refer it to someone who can, and you can jointly manage the case with the other vet that you are referring the case to, so that you can also benefit financially. Or the vet can do the primary management and allow you to continue with the post-op management, so that you can also, so it's your client. The idea is not that when you refer a case, somebody takes over your case. So for the senior vets who probably take on referrals, as much as possible, let us not try to commandeer these cases, so that we keep encouraging referrals. Sometimes the younger vets are scared of referral because they will lose that client. So please, let's encourage them to. Okay, next slide. I think the next is on referral, the process or the procedure for referral. Move to the next. Also, we can read it out. Thank you for granting me this audience, and also thank you for your attention. Thank you very much.
Yeah. Thank Prof for this very highly inspiring lecture that you have given us today. And like I said, when I said you are the best or one of the best on this field, I wasn't trying to praise you unnecessarily. I was saying the truth straight from the heart. And everyone who has listened today must have known that they have gotten it from the best. For me, you remain my mentor in this kind of, in this part of veterinary medicine. And for me, I also want to tell the organizers of this co-talk series that 40 minutes is not enough if we are going to be very meaningful in whatever we're doing in this series of lectures. It's not enough. I would have wanted Prof to do a part 1 and a part 2. All this later part of the should have come in the part 2 of this lecture, which I'm sure he will gladly oblige. So that would be for the organizers. For me, I have listened very carefully to what Prof has been telling us, and I'm worried about a particular thing which I have noticed over time in fracture management with cases, even from our own hospital and even from some other hospital. It is not about the science, but it is about the aftermath of fracture repair. I'm talking in terms of rehabilitation, post-operation rehabilitation of the case itself. If you look at the various clinics and hospitals, most times when you finish a particular procedure and the dog will have to stay with you for maybe another 3 weeks or 1 month, or even in some cases over 2 months. And then it involves a lot of costs. And these clients are not able to pay this cost. For my own case, I've lost a lot of money in terms of after repair and everything, and then you have to keep this dog with you, you have to keep the patient with you, and then for 6 weeks, the patient is with you, and then you give the cost to the owner, and they say they cannot pay. But the thing is, if you release these dogs or this patient to the owner to manage with instruction, they mess up the case. And because you are the one that did the surgery, they come back to you that the surgery has failed. But just because they cannot, keep to your instructions. So it's a dilemma for me, a choice between the devil and the deep blue sea, so to say. So I don't know what Prof will say about this, because if it's in the teaching hospital, you are everywhere. I mean, the cost can be managed, but we are for business. Every cost counts. Every cost counts. I cannot keep a dog in my kennel for 6 weeks. If it's not going to be ready to pay like 6,000 per day or 7,000 per day, and it's even more than the cost of the surgery itself. And if I release, they will mess up the case. So I found myself in this kind of issues that has rubbished whatever intervention that we have put in this kind of cases. So I don't know what the Prof would say concerning this, please.
Yes, we've equally experienced similar situations, but hello, can you hear me?
Yes, very well.
Yeah, what I've always suggested is that when there is such a situation, identify a younger veterinarian who will be able to get by with far less than you. Attach him to that case, especially a veterinarian who happens to be around the locality where that patient is and who can afford to check on that patient 2-3 times every day. Because as you said, being in your practice, for us in the teaching hospital, is not a problem. Because our salaries are going to flow, everything flows, but somebody in private practice has to be considerate of this sort of implication. So what we do is that we usually de-refer, if I may use that, or reverse referral. There are cases in which a reverse referral is indicated, where for one reason or the other, the senior vet who a case was referred to would not be able to continue the management, such as a situation like this. So you could discharge that case along with, or invite another veterinarian, introduce that vet to the case, and then discharge that case under the care of that other younger veterinarian who can afford to take what the clients probably will be able to pay. And at the same time, you already have somebody that you can always call on to. How is that patient doing? What is the problem? Is everything getting on fine? I think that's a way we've dealt with that with quite a number of cases that we've had. In our own case, it wasn't because of the money, but in some situations, the clients just indicate that to be coming, going, and things like that, it's difficult. And if there are referral cases, they came in from other towns. So for those who are taking care of those animals to remain there, pay their accommodation and other things, it's going to be too expensive for them. Because there are some of these referred cases that the client or whoever has to stay back. Otherwise, if they go, you are going to have problems managing such animals. These are highly trained animals that are usually security animals, and they could be problematic to deal with. So usually we discharge them with clear instructions to another veterinarian, a younger vet, who will be able to settle for less. So he takes care of that case, and he keeps giving you an update on how the case is doing. If at any time you think there are situations, you can request that they bring back the patient. So that's how we've dealt with cases similar to this. I hope you'll find that useful.
Yeah, I think it's something that is worthy to be tried. Thank you so very much.
We call it reverse referral.
Reverse referral. Okay.
Yeah.
No problem.
The normal referral is from the small guy to the big guy. Now the reverse referral is from the big guy to the small guy.
The small guy. Okay.
Yeah.
I think it's going to be very useful.
Yeah. All right.
So I want to hand over now to the MC so that Dr. Wakunobi can conduct the Q&A session. Thank you.
Okay, thank you so much, Dr. Tunji, for helping us out. And we know that you're in transit and you still made it a time and date with us. Thank you so much. Safe trips. I will hand over to Dr. Inzewan Kunobi now to help us with the participatory session. If you have any question, you can drop it in the comments or kindly raise your hand. Thank you.
Yeah, thank you so much. And I'm really elated to be here. I've got every reason to thank God that I was able to make this presentation. And one thing about presentation is sometimes when somebody's making a presentation, even very short presentation, people start sleeping. But I can see that this very long presentation, we're not in one location, but for me, I didn't even feel the time that Prof has taken to present this, to make this presentation, because it was quite interesting. I'm not a surgeon as a surgeon, you know, but I really enjoyed the discussion, the presentation. Prof has taken us through what he called the definition of management, fracture management processes, and areas that he covered included fracture classification, fracture healing, fracture evaluation, fracture management, referral services. There is something that Prof said that I know that all of us will take that as a one-point message that I take that personally, that in evaluating fracture cases and management thereof, we should also take cognizance of the fact or the place of soft tissue, possible soft tissue damages because that will add to the sources of failure, as the case may be, of a fracture management process. So the floor is open, and like my daughter was said earlier, you can drop your questions and we'll harvest them from the chat box, or you just indicate your interest to ask questions and by raising your hand. But please, let us be as brief as possible. Don't tell long stories. Just go to the point and ask your question. After that, Prof will respond to them. Thank you very much. So we are on. How you also helped me in harvesting especially the question that will be asked, dropped in the chat box. I'll try also to harvest some from this end. Thank you. So, is there any question on the chat box already? I think
I saw one.
Appreciating, okay.
I saw one. Somebody asked sterilization of implants.
Yes. This one on sterilization of orthopedic, whatever.
Okay. I've just written it down. I think so that we can take a few questions, I think, before I respond.
Yes. So we have from Obai Jennifer, what is the best way of sterilizing orthopedic implants to prevent infections? And since animals should be on antibiotics ahead of orthopedic surgeries, how do you decide the choice of antibiotics? From one of us here at LMS, there is a question on what is the best way of sterilizing. So it's the same, the same question. I think, I don't know. So from Jennifer, what is the best way of sterilizing orthopedic implants? And then the issue on about antibiotics and choice of antibiotics to use for post-surgical treatment.
Okay, so am I on the floor, sir?
Yes, because I've not seen. I think you can just take that one now.
Okay,
and,
sir.
Yes.
Okay, I think on the sterilization of implants stroke instruments, basically I'll take them all together. One of the slides that I have over there is on what I call budget sterilization. Unfortunately, as I said, time, I've been issue. I knew there were some challenges with time, but the best form of sterilization is usually autoclaving, moist sterilization under pressure. That's usually the best form of sterilization. But not everyone in practice can afford an autoclave. So I gave some options of what I called budget sterilization. So if you do not have an autoclave, there are certain things that you could do to make sure that you still get something as close to. One of the things you can do is to be outsourcing your sterilization. If you have a hospital, a clinic, or some other facility near you, whenever your instruments have been used, you package everything together, you take it to them for a little stipend, they will sterilize it along with their own instruments, and then you take your own instrument back. That way, if you cannot afford an autoclave, you can still get the benefits of autoclaving. Another way you can circumvent this is by using the time-honored old kitchen utensil, pressure cooker. The pressure cooker works on the same principle as an autoclave. And I've had situations where I've used a pressure cooker for sterilization of surgical instruments as opposed to an autoclave.
Prof, I can't hear you. I don't know about others. Prof, are you still there?
I also cannot
Yes.
hear.
Hello, can you hear me? Hello?
Yes,
Yes,
we can
now
hear
we
you
can.
now. We can hear you now. Yeah.
Sorry about it. I was just answering the sterilization of implants stroke instruments, and I said the best form or the best way to sterilize them is by the use of autoclaves. That is autoclaving. However, where you do not own one of the things you can do is find a facility near you that has one, and you can submit your own instruments. They are wrapped already and labeled. They sterilize them along with their own, and then you can take back your thing. That is one way to save cost and still get the benefits of autoclaving. Another way is to improvise the autoclave by using a pressure cooker. The normal pressure cooker we use in our kitchens. Okay? An autoclave will give you about 20 pounds per square inch, 15 to 20 pounds per square inch, okay, which is the pressure required at about 121 degrees Celsius for about 15 minutes. A pressure cooker gives you about 30 pounds per square inch, which is the pressure is even higher than what you obtain in an autoclave usually. So you put your instruments there, you put on your autoclave on a source of heat, and once the chip, opens up and it starts releasing steam, that's the pressure valve. Once it opens up, it means that 30 pounds per square inch has been achieved. So the use of this is a very important factor. As I said, there are other things. You can do a dry heating. You put it in an oven to attain a temperature of about 160 degrees centigrade for about 30 minutes. That can also do it. But the most effective is the use of the autoclave. If you don't have an autoclave, a pressure cooker is something that is manageable. It's portable. You can carry it around, and it will give you the same quality as what you get in an autoclave. Irrespective of what you are using, however, it is always recommended that you have a strip of autoclave tape inside your instruments, because the autoclave tape has a marker on it. It will change color if the sterilization conditions have been met. Forget about the pressure gauge will tell you, yes, you are at 15 pounds per square inch. Yes, it's been there. Your time will tell you it's for so minutes. What is important is, has autoclaving, has sterilization been achieved? And that autoclaving tape is what will tell you that. It will change color whenever those conditions have been met. So whenever you are autoclaving or you are using a pressure cooker or any other source, ensure that you have an autoclave tape there and ensure that that color change is noticed. If the color change is not noticed, it simply meant the sterilization conditions have not been met. And it is important in orthopedics that your instruments must be sterile. Otherwise, you end up with a post-surgical infection, and you are likely to, that case is likely to be messed up. Thank you. I hope.
What about the issue about antibiotics, operation antibiotics, the choice.
There are different categories of antibiotics. There are certain antibiotics we refer to as bone-seeking antibiotics. Antibiotics like chloramphenicol, chloramphenicol, antibiotics such as tetracyclines and others are referred to as bone-seeking antibiotics, because these antibiotics have the tendency to concentrate highly within skeletal structures. So they are preferred when it comes to the choice of antibiotics. There are a whole range of newer antibiotics now, of course, but antibiotics that specifically fall into that category of bone-seeking antibiotics are preferred, because other antibiotics may attain high concentrations in soft tissues. But if you have an infection or already a contamination within the skeletal structure, too bad for you, because those antibiotics do not achieve high concentrations in bony structures. So you are better off using a bacteriostatic like tetracycline that will achieve very high concentrations in bones than using one that does not attain to that category of bone-seeking antibiotics. They are preferred when you are dealing with orthopedics or trying to prevent orthopedic infections.
Okay, so we move on. We have a few other questions here from Dr. I hope Aminu. Please, if you're a prof, pardon me, So first of all, you're a doctor before you became a prof. Anyway, so can open reduction and internal fixation take place on equine? If yes, how? Now also then from Dr. Monday Ojemia, how easy is it to get the fiberglass that you have advised us, you told us is a better option to POP? How easy can it be assessed? He is asking for practical demonstration, but I leave that to you to answer. But I doubt if you can do practical demonstration here on this call. Then from Honor, whatever, please say a word on multimodal pain medication in orthopedic fractures. Answer: what drugs or approach will you advise as first choice? Now there's another one from Sogebi. Sorry if I massacre your name here with me. Considering that cutoff is about bridging between gowns and arm, which is true, can you help with other aspects of surgery apart from diagnostic imaging that should come to play for a successful outcome? I really don't understand what he's saying, but I know as a prof, you know what he's saying, you know. Then from Chia Number, Franklin, what kind of reaction to implants, immobilizing materials, if any, are to be expected, and the best way? Okay, maybe he's trying to say what kind of reaction will we have from implants and immobilizing materials, you know, so, and how do we manage such emergencies, if I may call it that? Then from one of us here in the house, LMS, what kind of reaction to, that is the same, I think it's the same question, you know. So Prof, these few you can take.
Okay, sir.
I think by the time
let me start with the first.
Just close this session so that we don't stay here
starting
for
with
too long. Thank you.
Open reduction and internal fixation in the equine. Theoretically, it is possible. In practical terms, it is difficult and very, very challenging. Difficult and very challenging because we've tried it, quite a number of horses have been brought into this area with fractures, and we've tried it. One of the things we realized is that in a fairly young foal that is just coming up, a very rigid fixation, such as the use of plates, may succeed. But when you have a fully matured horse, we realize that it's usually an exercise in futility. The extent and the intensity of management that is required and rehabilitation is often not worth it. At the end, once a horse is demobilized for a few weeks, that horse is gone. Even if you succeed in dealing with the fracture, the muscle activity would never resume in such a horse. And more often than hell with it. So in theoretical terms, yes, we've realized in foals, young growing horses, we've had some successes using something as, by bone plating, which gives a very, very rigid fixation. But in adults, please don't waste your time. You are better off just euthanizing that patient because it wouldn't work out. We've tried it. We've kept horses for a month, 2 months. At the end of the day, we had to euthanize them. It did not work. The intensity of management required. You need a pool bath for the horse to be exercising and things like that, because a horse must exercise consistently. So even though fractured, you must find a way to get that horse to continue exercising. So the requirements are so intense that most practices just do not have them. But there are a few specialized, centers that indicate it is possible to do that. But even when they succeed in managing such fractures, those horses are never returned back to work. They are usually limited to only breeding. So they can now be used for breeding, but not for racing and things like that anymore. I hope I've answered your question. Fiber glass cast is very common. You go to any of these pharmacies around and you ask for it. It's available. Just as you go in there and buy a POP, it's available. The technique for its application is also similar to that of POP. You do the same thing. You dress you put on your layers of cotton wool and everything else. You get your fiberglass cast. You soak it in warm water and you just wrap it around the wool, around the cotton wool base, just as you do with the POP. But it's just that it need not be as thick as POP anymore. And when it dries up, it's usually very strong and very firm. Okay, so it's fairly common. You can get it in any of the pharmacy establishments. So if you are dealing with puppies, 1 or 2 layers is usually adequate. So you realize that it does not put on so much weight and inconvenience, such animals, but it's common. Multimodal, pen medication. I think this is simply based on the concept that no one analgesic is perfect. They all have their problems. So the concept of multimodal therapy is to ensure that you use a cocktail of analgesics. Some probably going IV, a little bit of local anesthetics going in there, general, analgesics, such as paracetamol, especially the injectable versions of it. So it's a combination of different drugs. That's just essentially what it means. So you just look at what drugs are available in your environment, try to give a little bit of this, a little bit of this, because quite often in fracture management, analgesic administration may have to be protracted. And because these analgesics have their own potential side effects, it's not usually advocated to administer them over a long period of time. But multimodal allows you to mix different, so you are cutting down on the quantity of any of these drugs and thereby cutting down on the toxicities of the various drugs and combinations. But there are various combinations that have been suggested in the literature to achieve multimodal therapy. Next, I think reaction to implants. Well, if your implants are sterile and they are surgical grade stainless steel, you are not supposed to have any reaction to it. If, however, they become contaminated, you will have a problem. If you are using a metal implant that is not surgical grade steel, the body may react to the metals depending on the kind of metals that are within such a material that you are using. One of my PG students had worked on the use of xenografts, let me use that word. What we did was, we realized that even when we use plates, one thing becomes necessary. You go back for a second surgery to remove the implants. And we asked ourselves, why do we have to go for 2 surgeries? Isn't it possible to use a biodegradable material so that there will be no need for a second surgery to go and remove it? So he tried quite a number of things. At the end of the day, we realized that we can construct plates using the femoral bone and the humerus of the camel. And they are so strong that they are almost as strong as the plates, the metallic plates, because the camel bones are really hard and firm. So we constructed them and we used them. Instead of using the stainless steel plates, we used constructed plates out of the skeletal structures of the camel. And we simply, so it's the same technique, we put it there. We use, of course, stainless steel screws for that. But after fracture healing, the bony structure was integrated, it melted into the normal tissue. There was no need for us to perform a second surgery because they are tissues that are osteogenically similar. And when you have tissues that are histologically similar, resorption can take place in such a situation. So we've realized that, but of course, we had to subject it to some treatment, deprotonating it, and so many other things to make sure that allergy does not ensue. But so the bottom line is, if you are using stainless steel, if you are using things like titanium, or if you are using this sort of implants such as ours that are fabricated, but if well treated and deprotonated, you are not likely to have any reaction with the use of implants. So I'm also a little bit confused on the question by Professor Shogebi. I didn't also get it much, really right.
Maybe we'll get back to him so that maybe we'll get the correct question and we'll pass it on to you, and whatever answer you give us, we'll put it on the general platform of the lecture series. And I want to tell everybody, I know that many people have questions to ask. Whatever question you needed to ask, just send it through the general platform of Koto lecture series, and we'll pass it on to Prof. When he gives us the answers and solutions, we'll share with you in the general platform. But I will not let Prof go without asking him to bless me, so to speak. When he said idiopathic fracture, I was thinking that is a fracture of unknown cause, but now I know that that one is a fracture that is inadvertently caused by us in the process of managing whatever. And now, when Prof, you took us through clinical examination, one of the stages is visual. I can understand discharges, fluids, gait, disposition. But when you say coat, I don't know what coat, the relationship that coat has to do with the coat of the animal has to do with managing a fracture. I don't know if you can just briefly enlighten us on that. What has the coat got to do with management of a fracture that we need to take the visual evaluation of that?
Okay.
Coat, yes,
okay, sir. The code will usually first and foremost give you an index of the point of impact. You may see bruises, you may see cuts, you may see other signs that will suggest this is the point at which whatever force it is impacted that tissue. The nature of the code may also give you an index on if bleeding is occurring underneath it. Urticaria might be a feature. So the code will give you two things. One, they may give you an insight or the possibility of the soft tissue level, extent of the soft tissue injury. Two, they help you in localizing where the point of impact is and potentially where you should concentrate your examination. Okay. So when you are visually looking at the patient, take note of some of these things even before you start touching the patient. Yes. So that's what part of what. And then, of course, you may see hemorrhage and things like that. These are all features you can see on the codes that might be important for you for the purpose of both observation and prognosis.
Thank you, Prof. Hawa, I hand over to you for continuation of the program. And thank you, everybody. Hawa?
Okay, thank you. Hawa stepped out to actually make the final presentation, which is to thank all of you for coming on to enrich this discussion. We have our team actually on a surgery as I talk, and I can never wish for a better forum where you have the mentor and the mentors of the mentors, Dr. Kunle Abiade, Dr. Ezenwa, Dr. Hassan Zoaka, Professor Hassan Zoaka, Dr. Tunji Nasir, and every one of you present. I also saw my ore for life, Dr. Professor Shogebi, making some remarks. Thank you so very much for coming to share your experience. First, let me also go quickly to thanking Professor Hassan Zoaka, who has always been encouraging this lecture series through suggestion as regards the topics and how it should go. And today he is also making his presence in Abuja to lead in the series of orthopedic intervention that we are going to be presenting on this platform. Thank you so very much, Prof, for your time. And I will also, because you keep saying we should share the slide, I'm also asking again, we want to share with everyone that has attended and also couldn't attend, because I have received private message asking if we can share. And secondly, to also thank Dr. Tunji Nasir, who is in transit in Heathrow and had had to step aside to actually be part of this. We appreciate his intervention too in what he said in the beginning and also after Prof's presentation. We are going to adjust time, and then we will also try as much as possible to make it more lively in terms of having some cases being presented on this. I will discuss with my colleagues on the team in making sure that we get the full benefit of this time out. Thank you, Dr. Tunji and Dr. Ezenwa Nwakunobi Hawa Bola. Thank you so very much. I would like to advise and to also suggest that SAVAN conference is upcoming. It's going to be a 2-day intervention, and the conference is also going to be getting, revered experts to be making presentation from United States, from Wasava, from within the country, and from surgery to internal medicine to laboratory medicine. We are going to be having a full blast, full complete days of presentation by revered colleagues. Abimbola Oshin and many others from South Africa, from United States have signed up, and they will be coming in here. Please, it is important that we borrow skills. We may think it's expensive, but exactly what will take us to where we want to be are some of these conferences that the organizers are putting together. What I learned today, even though Professor Hassan is my teacher and my mentor, I have actually learned a lot of things today. And then going forward, I am going to be applying those skills. So it is that moment that you come to step up your practice. I think the fee will be announced by this week or early next week. But on Kotog platform, we are going to be advertising that. Next week, 23rd July, is also continuing education by the Veterinary Council of Nigeria. If you have not registered, please go ahead and register and then join that moment. No knowledge is lost. There are a lot of people that will be coming from outside, our own brothers and sisters and colleagues, including the president of Wasava, or is it the president of WVA, Dr. Toyota, will be on the conference too. So I think it's important that we register and avail ourselves these opportunities of stepping up our skills or honing our skills in different areas of specialization. On behalf of my colleagues here at Kotog, thank you so very much for making it with us, and then we see you next month. We'll see you next month in Lagos in SAVAN. We'll also see you next week in VCN, but also Kotog will be in the behind the scene, getting a lot of lessons that we are going to also step down from some of these big conferences coming up. Thank you so very much, and good afternoon. I think we can please switch on our cameras so that we can have group photograph. Switch on our cameras so that we can have group photograph.
Yeah. We still need some more. Okay. Please, your camera. Switch on your camera for a photo. Aisha Ibere, Professor Baka, Omar, Raymond, Najib. Seconds.
Thank you. I We'll get the permission of Professor Hassan, the presenter, and then we'll share the slides with all of you. Thank you so very much for coming through.
Thank you very much, sir. We're very grateful.
Thank you, sir.
Thank you, boss.
Thank you.
Thank you and bye-bye.
Thank you, sir.
Thank you, sir.
Bye, bye-bye.
Thank you.
So much, Prof. And thank you too to our wonderful organizer.
Thank you very much. Thank you very much. Bye-bye.
Thank you very much.